Good evening, and welcome to the John F. Kennedy Jr. Forum. My name is Patrick Amares, and I'm a sophomore studying government at the college. I'm a member of the JFK Jr. Forum Committee here at the Institute of Politics. Before we begin, please note the exit doors, which are located over at the JFK street side and the park side of the forum. In the event of an emergency, please exit through the doors closest to you and congregate in the JFK Park. Please take a moment now to also silence your cell phones. You can join the conversation tonight online by tweeting with hashtag Opioid Forum, which is listed in your program. Please take your seats now and join me in welcoming our guests, William Brownsberger, Mark Eisenberg, Alex Hogan, and moderator, Sheila Burke.
Thank you very much. We are pleased to be here and pleased to welcome all of you to the forum for, I know, a discussion about something that we all care very deeply about and has affected so many of our lives. I also want to note that State Senator John Keenan is with us, who is from Quincy, and we are pleased to welcome him as well to the conversation, somebody who's also following this very closely. One really need only look at the front page of the newspaper or listen to the news on a daily basis to hear the calls for the need to address the opioid crisis in this country. We hear of increases in opioid-related mortality that is fueled by inappropriate or misguided prescribing, an increasing use of illicit prescription and illegal opioids. In Massachusetts in 2016, there were 267 deaths due to prescription opioids, about 630 due to heroin, and 1,550 due to synthetic opioids. Nationwide, over 1.7 million people report having prescription opioids. About 620,000 a heroin addiction. And overdose deaths nationwide have quadrupled since literally since 2001 to 2016, from 9,492 to 42,249. Staggering numbers in terms of the scale of the problem in this country. In addition to the cost of human lives lost, there's also the cost to the country that comes in a variety of ways, both in the case of the healthcare costs that we incur, the patients that Mark sees and others see, in terms of incarceration costs, lost productivity in the country, really a host of things that impact us as a country that are estimated to be around $78 billion on an annual basis. And while this is a problem that we face, we are not alone in facing it, but the closest country in terms of the scale of the disaster are our friends to the north in Canada. But they fall far short of the degree of the problem that we're confronting here in this country. Nobody disputes the problem. None of us here tonight will dispute the problem exists. But as so often the case in public policy, for those of us who are engaged in public policy, while there's little disagreement on the fact there is a problem, there is often a disagreement on the cause of what has led to it, and on the solutions. And frankly, on how we would measure success. What would we consider success in addressing this issue? So keep in mind the users, which we'll talk about tonight, may not be who you think they are. And the challenge may be faced by not who you think it is faced by. Yes, it could be a 16-year-old that tore an Achilles skiing, had surgery, was given Vicodin, or either by a physician or by a member of the family, and became addicted. But the typical user is not that young person getting high. The typical user is between the ages of 40 and 64. It is somebody that essentially has been a long-term user as a result of chronic illness, a debilitating disability, or a variety of really issues that they confront. So we have to think about that in terms of the problem we're trying to solve and the solutions. 70% of those, and this is a Kaiser study that was done with the Washington Post, said they had a disability or a chronic issue, and more likely lived in a rural area as compared to an urban area where it is far more difficult to gain access to treatment. Among almost all long-term users of painkillers, most of them received them from physicians. They were begun as a prescription and then became out of control over a period of time. So lots of discussion about what to do. Last year, the administration essentially put out a 5-part strategy that they were going to propose. 1, better addiction prevention, treatment, and recovery services. Secondly, better data, so we could track what was taking place. 3rd, better pain management, including prescribing behaviors. 4th, better targeting of overdose reversing drugs and their availability. And 5, better research. Today, the commissioner of the FDA, Scott Gottlieb, called for a national electronic prescribing platform, one to ensure appropriate prescribing and to allow the collection of data that allowed us to examine what in fact was occurring. Others have suggested, and I hope we'll touch on this evening, that law enforcement, the judicial system, has to be part of the solution. No doubt the solution really is going to come up from all of those things, all of those measures. It won't be one single thing. GAO, the Government Accounting Office or Accountability Office, has now been asked to examine what the administration has actually done. So that process will be underway. There are a myriad of legislative initiatives pending at the federal level. We'll hear, I hope, today about some of what's occurring in terms of Massachusetts. And so we will have the chance to talk about the proverbial front line this evening, from what is occurring here in the state, what unique circumstances you're facing, and what opportunities there are to address those issues. We have with us State Senator William Brownsberger, representing Belmont, Watertown, and parts of Alston, Brighton, Back Bay, and Fenway. He is the chairman of the Senate Judiciary Committee, critically important in terms of looking at some of these solutions. Dr. Mark Eisenberg, who's at the MGH, whose current focus is on harm reduction and on overdose prevention, has spent a career looking at these challenges. And then finally, Alex Hogan, who's a multimedia journalist who's created a documentary about opioid abuse and looked in Somerville as an example, not because Somerville is unique, because it is a representation of what we're seeing in many communities around this country. So I've asked each of them to begin with some brief opening remarks to give us a sense of where they are and what some of the challenges are they're confronting and what some of their concerns are. And then we will leave plenty of opportunity for them to talk with one another and for all of you to engage with them as well. I will point out that there are microphones here on this floor as well as microphones upstairs in the salmon runs. And when you in fact approach a mic, I'm going to ask you to give us your name, give us your relationship to the university or to your community, and your question will end with a question mark. So we will try and get through as many as we can this evening. So I'd like to begin with Dr. Eisenberg and hear a little bit about what his experience has been. Mark.
So as Sheila mentioned, I'm a primary care physician. I work in Charlestown, a working class community 5 miles north of here. It abuts Somerville, where Alex lives. And I've been profoundly affected in my career by the opioid overdose epidemic. I've lost over 24 patients from overdose deaths in the past decade, and I'm taking care of scores of patients with severe complications of their drug use. Last week I was sitting with a patient of mine, Dennis. He's a longshoreman in Boston. He told me that 20 years ago there were 5,000 longshoremen who had their careers in Boston. Now there's only 300. Those well-paid union jobs have been replaced by minimum wage jobs. So I think, although Purdue Pharmaceutical, I think, deserves lots of blame for what's happened, I think we'd be still having this conversation even if it wasn't for Purdue Pharmaceuticals. We'd just be talking about a different drug. While the opioid overdose epidemic has grabbed attention, it's known that crystal methamphetamine overdose deaths have increased 2.5-fold in the past decade. Alcohol-related deaths have increased 28% and vastly exceed the number of deaths to opioid overdose deaths. Suicide has gone up. For the first time in our history, we have a population of people whose life expectancy has diminished. And I think that's because of the loss of well-paid jobs and the lack, people can't work for a living wage, like there's no affordable housing, and that's created this epidemic of drug use. So what's happened now is we're seeing this crackdown on opioids and OxyContin, and all that's done is led to increased potency of fentanyl. So interdiction has not worked during Prohibition. It just succeeded in having alcohol that was more powerful. The war on drugs has created marijuana that's been more powerful. And now that we're cracking down on heroin, the fentanyl and carfentanil, which is easier to manufacture and smuggle, has just made its way into the community, which leads to people overdosing and dying.
Good. Thank you, Mark.
Yeah.
Senator, you have a unique position in looking at what the judicial side of this would look like and what you might do, but you've gone through a journey and looking at what the nature of the problem is and what some of the solutions might be. So your thoughts.
Thank you. If you look at the history of science knowledge, it often new insights follow the introduction of new instruments, like, okay, microscopes, we can see there's little things in the water and so forth. Hubble telescope, see new parts of the universe. In drug policy, the Hubble telescope was cheap drug testing. Cheap drug testing became available for the first time in the late 80s, early 90s, and it really changed our understanding of drug abuse in America. The data we had before was mostly survey data, and that sort of paints a picture of drug use sort of spread evenly through society. But when we started to have cheap drug testing, we were able to systematically test all the newborns in different hospitals for exposure to cocaine in utero. And we were able to start testing everybody who was arrested in our major cities. And it was a sort of a blinding set of numbers. What it told us was, first of all, that the problem of drug abuse was much more widespread than we'd ever believed. We had numbers like 500,000 frequent drug users in the United States, whereas based on the arrests, it was millions and millions. We learned that it was actually much more concentrated in areas of high poverty. You had poverty hospitals where 30% of the newborns were exposed to drugs in utero. And it was extremely concentrated in the criminal justice system. Probably most of the drug users in the United States got arrested within a 1 or 2 year period. And that insight focused a lot of attention in this building. Some of the academics who were present in this building at that time were very focused on the issue of using the criminal justice system to fight addiction, using the power of the criminal justice system to create incentives for people to stop using drugs. Okay, I have an addiction problem. I'm going to be on a probation for 18 months, and during that period, I'm going to have to provide a urine sample 3 days a week if I test dirty. I know I'm going to go to jail with swift, certain sanctions, and the result is going to be that a light's going to go on that using drugs is not good for me, and I'm going to stop using drugs as a result of those new incentives. Coerced abstinence, coerced treatment, those were thoughts that had a lot of appeal then. They were thoughts that made sense to me. I was involved in a conversation here that was going on between the Kennedy School and the law school and the medical school at that time. The then President Rudenstein was very involved in trying to have interdisciplinary conversations, and there was an interdisciplinary working group on drugs and addictions, which I got to kind of tag along with. I was a prosecutor at the time. I was an assistant attorney general in Massachusetts. So there's a lot to talk about that. At a certain point, I got tired of talking about people with addictions, and I decided I really wanted to talk with people with addictions. And I started working in drug courts as an attorney, as a defense attorney, and it only took about 90 days of that work to just completely change my outlook. I mean, the idea that locking people up as a result of their relapse would be helpful just became just went by the waysides for me. I mean, somebody's doing sort of okay, they're kind of in recovery, and they have a slip, and as a result, you lock them up for a few days. Well, you lock them up for a few days, they lose their job, and then lose their job, they lose their apartment. They lose their apartment, they probably break up with their girlfriend, and the whole thing's over. So you might as well just go back to the streets and keep doing what you were doing. So the criminal justice system, I came to understand, as a very, very blunt instrument. And really, if you think of the risks that people are taking every day to use drugs, I mean, just the spectacular health risks, and really the street violence risks that people are exposing themselves to use drugs. The idea that just adding this additional threat of going to jail, as if that was much worse than some of the other things they're risking, would somehow change their mentality, move them along the readiness for change line, doesn't really make sense. So I've moved much more to much more interested in a harm reduction approach. Let's use the criminal justice system as a venue for encountering people and trying to provide them voluntary treatment and the support they need as much as we can. Let's look for all the other ways that we can to come into contact with people and provide them support, health protections, access to treatment. And so in that context, I think of safe injection facilities as an opportunity to do that. So the evolution that I've gone through on those issues is the evolution I think that a lot of people in the system are need to go through, because the idea of sort of the safe and SIFs seem kind of an enabling thing, and they don't. The idea of harm reduction is even 20 years later is still for many people in public policy a hard idea to sign up for.
Good, thank you, Alex. You have confronted this from a community standpoint. Using the opportunity in your community to observe and to talk with folks, and as a filmmaker, capture their impressions and their views of what in fact is taking place. I wonder if you might begin by showing us some of the work you've done.
Yes, so I work at Stat News, which is a health and science vertical from the Boston Globe. We cover the opioid crisis quite in depth. In my time working there, I've only been there for 2.5 years. I've had to go to 2 funerals for close friends that have passed away. I've personally been living in my community, the opioid epidemic for almost 20 years. I lost one of my closest childhood friends in 2001. And ever since then, it's been pretty steady. We've lost, I'd count 6 very close friends I lost to the epidemic, and then another 10 or so that from a group of friends, more extended group of friends. So I've been living with this epidemic for a while, so it's been kind of interesting to report on the crisis because I live with it so closely. I got the opportunity, starting about last year, to produce a short documentary about my community of Somerville, hoping that by taking a deep dive into what happens to our community, which is pretty typical of communities everywhere, but if we can look at how it can happen in one place, we can kind of illustrate how it could happen anywhere. And I did bring a short clip from the film, if we can cue that up.
2001, Matty O'Brien became the first of my friends to die from an overdose. He was just 17 years old. For many of us, Matty's death was the beginning of the overdose nightmare that continued for the next 16 years.
I expected that to be a wake-up call to the community. Unfortunately, it had the exact opposite effect. It kind of just spiraled from there.
Some pharmacies stopped stocking OxyContin because of all the robberies. This shortage led to skyrocketing prices on the street. A lot of users turned to a cheaper, deadlier option: heroin.
A lot of people that do the pills, like, wow, heroin's a lot cheaper, let's try that. And then they don't realize it might be a little more addicting when you start using a needle,
Once the heroin was in the streets, it was heavy. It was obvious.
It kind of like fell in our laps, and, we just ran with it.
When they ran, I often wondered what it's like, in your sobriety, having to live with the things you've done while you were high.
Rob, steal, take it from your parents. I'm actually grateful to leave that life behind,
Kevin lost his car. He never had a car. He got my old car impounded. You couldn't leave anything out in the house. It would go missing.
One day I came home, and I'm looking around the kitchen like something's wrong here. And the air conditioner was gone. All the air conditioners were gone, right out of the windows.
I have a modest train collection, and I'm on eBay, and there's my stuff.
Robbing my mom and my dad. Like, you know, it's insane, right? Like, I didn't sit there and say I want to hurt my mom and dad, right? Absolute torture. I mean, I was an emotional terrorist, you know what I mean? They were heartbroken. They didn't know what to do. Their hands were tied behind their back, and I was literally running all over their hearts, you know?
So I think a part of that clip I want to show is that, you know, this drug is so powerful, and the addiction is so powerful. They drive people to do some, you know, things they would never do. You know, they were stealing from their parents, robbing strangers. You know, these are not criminals, a lot of these kids. And I think that's one of the effects it has on the community is, you know, they're hurting not just hurting themselves, but they're hurting their families and they're hurting their friends. And the scary part is they know it and it hurts them, and they feel tremendous guilt about it, which is a vicious cycle, because that guilt they feel often they turn to drugs to self-medicate, and then, you know, if they get clean for a little bit, like the senator mentioned, now they may have a criminal record, they may have a gap in their employment history, and they spend there so much time feeling that their only goal is to get clean, I just need to get clean. If they succeed at that and they stop using for an amount of time, it's like, now what? And that, I think, is a huge problem, is figuring out there, because once you have someone that has been using and they have some success, is what that next step is in order to prevent the relapse.
So let's examine each of these pieces and where the solutions seem to lie. As I indicated, there seem to be lots of pieces, lots of strategies on both the care side, the prevention side, the treatment side. But let's begin with the criminal justice system. Senator, you mentioned that you thought there was an opportunity to use the criminal justice system in a way that essentially helps to address this issue rather than simply turn to punishment. And I wonder, in the context of the work that's going on in Massachusetts and some of the legislation, what are you thinking about as methods to essentially remove the really sort of the challenge that putting someone in and the repeat kind of return that you see? What's the solution here? How do the drug courts begin to examine this question?
Well, you know, the drug courts, my friend Roberta Leese is here, head of the New England Drug Court Association. We've been talking about this issue for a long time. I'm someone, actually, my biggest concern as a legislator, and this may sound funny, is actually to make sure we aren't going too far with drug courts, because I think there's a huge danger of what I would call net widening. You know, there's a population of people who have, you know, extensive criminal records, long addiction. You know, the minute they get out, they're going to go back to smashing windows and grabbing things to sell. That subpopulation of very, very deep involvement in the criminal justice system, deep involvement with addictions, those are the people that drug courts are for. Those very, very high-risk offenders. In practice, drug courts are a thing that feel very good for judges to do. I mean, judges have a hammer, you know, and you know, swinging that hammer every day and just punishing people doesn't feel right. But if you can now sort of use that hammer and punish them in the name of making them better and helping them and supporting them and having a conversation with them about how you're making them better and so forth, that's a very appealing thing to do. So a lot of judges like to do drug courts, and they want to do drug courts. So now you have a drug court, you know, in some new community, judges introduced a drug court concept, and they only have so much case flow coming across their desk. And so there's a huge tendency for them to draw too many people into drug courts. People who aren't those very high-risk people who just have a relatively limited drug problem of some kind. They haven't gone all the way down, the descent into frequent crime. And those folks can really be harmed by drug court. And that's what the evidence shows. And I've seen, the research evidence shows that. I've seen it with my own eyes where judges, destroy people by getting them into the criminal justice involvement that is not good for them. And we have that risk in Massachusetts right now. There's a lot of, I forget the numbers out there, but we have a few dozen drug courts in Massachusetts now, 44. Thank you. Many of which are sort of undersized. And you know that there's net widening going on to fill those drug courts. So that wasn't a positive answer about the opportunity for the criminal justice system. I'm more interested in something that I don't see as much of, which is simply the voluntary access to treatment that we can use the criminal justice system for. And of course, there is a huge emphasis that the legislature is very focused on, which is rolling out more access to treatment. So that's the big thing that there's consensus on doing, and that's treatment that people can get into a whole lot of different ways.
So Mark, one of the things that you focused on is that question, which is treatment, and the nature of that treatment, issues around needle exchange, issues around safe injection sites. Talk a little bit about that as a strategy and what kind of response you've gotten, what people's reactions are.
Well, first, in terms of treatment, only 3% of American physicians are waived to prescribe Suboxone, a life-saving medicine, and which is criminal to me. When we have something that's the leading cause of death in people under 50, this treatment should be more available. Only 20% of people with addiction are actually under treatment, so we need to improve access to treatment. In terms of your second part of your question, the one thing that all my patients who overdosed and died have in common with Alex's friends is the last time they used drugs, they used alone, whether it was in their basement or their car or their bedroom or a abandoned building. And if that last time they'd used drugs, they had been in a safe injection facility supervised by medical personnel, they may be still alive today. So not only am I seeing these overdose deaths, but these infectious complications, as we've talked about. Almost everyone with injection drug use has hepatitis C. Over the last 3 years in Massachusetts, we've seen rising rates of HIV among injection drug users. In Massachusetts, 9% of people with HIV acquired it from injection drug use, as opposed to in Australia, where only 1.5% of people got HIV from injection drug use. And that's because in Australia, they have safe injection facilities. So for patients who are able to go to these facilities, have medical personnel, be supervised, if they overdosed, have that reversed with Narcan. There's over 100 of these facilities in 10 countries in the world. There's been millions, literally millions of injections, and there's never been one overdose death in any of these facilities. And it's been demonstrated that people who go to these facilities are less likely to overdose and die. They're more likely to go into drug treatment because when they go to these facilities, they're treated with respect and dignity. They meet people who are helping to get them into treatment when they're ready for treatment. And so we need this. Everyone who's using drugs isn't ready for treatment, but when they're ready, this is an opportunity for them to get into care.
So the resistance that you're facing, I mean, it would not come as a surprise that there would be people who would be opposed and view this as almost an incentive for people to essentially use, that you've created an environment where it's okay to essentially be a drug user. Your response to that, I mean, in addition to the stats that obviously show that it is a safe way to avoid some of the public health circumstances that exist, and I wonder, Senator, what sort of you're hearing in terms of the legislature and how that conversation is moving forward in terms of whether it's needle exchanges or it's safe injection sites. There are also questions about how you essentially avoid the drug court. Where do you direct someone? To whom do you direct them in terms of a safe and secure place to be treated or evaluated? But I wonder at the state level what the legislature's reaction to this is and how that conversation is progressing.
Well, as I mentioned, there's a lot of consensus on making more treatment available. Treatment of, the residential treatment is something that particularly appeals to people, but all forms of treatment. The one form of treatment that there's a lot of ambivalence about is medically assisted treatment. And we're still having conversations about, using drugs to get off of drugs, what's up with that? And it never leads to them really leaving drugs. They don't get the perspective that they're much better off in terms from a health risk standpoint and from a crime risk standpoint if they're on getting medically assisted treatment. So it's surprising we're still fighting that fight. I think one of the other things that when we start talking about the SIFs, you have some of the same conversation. It's enabling and all that. But then there's another question, which is, where are you going to do it? See, we're having this legislative policy conversation. We're having this conversation here about safe injection facilities, but there is not a single entity in Massachusetts who has actually put its hand up and said, we want to operate a safe injection facility. We got a building, we got some money, and we're going to want to open a safe injection facility. Nobody's done that yet. Not one organization has done that yet. Nor do we have a municipality that has said, well, we have a neighborhood where we have a lot of people with addictions and when we really think that we could use some help of this kind. There is no municipal partner, no organizational partner, just an idea so far. And of course, as to the municipal partners, you do have the not in my backyard politics, not to pass judgment on that too lightly, but just to use the word, because that's what it is no, we don't want one right near us. So that is really where the conversation's at this point. There's an outside process, an outside the building thing that has to come together before we can really make much progress in the building. We as legislators are not going to pass legislation creating a construct like that without somebody to work with. You have to have a municipality and an organization to say, okay, well, what do you really need in this legislation? To do good legislation, you have to have somebody who's going to use it to talk to.
One of the things that you do have control over is the incarceration. And those who are incarcerated. And to what extent is there also a conversation about the treatment of individuals who, in fact, have ended up in the criminal justice system, are incarcerated, come in addicted, and then essentially how they're treated while incarcerated and what the strategies are as people are discharged? To your point, many of them are in fact not hardened criminals who essentially chose a lifestyle of smash and burn and steal, but rather are caught up in this system of capture and then incarceration. But then are they in fact, is there attention being given to what we're dealing with in terms of people that are in fact in our jails and how essentially to deal with them during the course of their incarceration and upon their discharge?
Well, my sense is that most of the sheriffs in the Commonwealth are pretty attuned to the reality. When I said sheriffs, because we in Massachusetts have a multi-level criminal justice system, in particular a multi-level incarceration system. We have a state prison system, Department of Corrections, which runs facilities for longer-term people. Then we have the houses of corrections, which are run by sheriffs, and the jails, which are run in conjunction with those by the sheriffs, which are shorter term, maximum 2.5 years in the houses of correction, and typically a huge amount of turnover. So the challenge for the sheriffs is to, number one, detox people or provide them with what they need to survive, having left whatever it was they were doing on the street and now coming into an environment where they can't get just what they were using so easily. So the sheriffs they detox, half of their people, ballpark, are coming in with some kind of issue that may need medical attention. So assessing that, making sure they get it. The sheriff's ability to provide them with a long-term recovery program is limited. Certainly for the jail population, because it's high turnover. They don't have them that long. For the people who are there longer, the sheriffs are drawn to the Vivitrol approach, the opiate antagonist approach. That resonates with the mentality of that's a little more palatable than a Suboxone opiate agonist approach. So we do have sheriffs that are using that, and they feel getting good results as a discharge plan. So basically, the model tends to be detox, talk therapy, Vivitrol. It tends to be what people are actually doing. And we were having a conversation. Are you still here, Senator Keenan? Where is he? Senator Keenan and some other legislators have been really leaders on the issue of trying to introduce medically assisted treatment into the houses of correction and the state prison. Although in state prison, you're talking about a very long maintenance period, right? I mean, you're talking people with sentences of several years or long years, and that's not getting a great reception so far. There's still a lot of pushback on that.
So one of the other things that's within the control of the state, and Mark, I'd be interested in your thoughts on this, and Alex, to the extent you've seen this as well, is prescribing behavior. That is the extent to which there are registries. That is the extent to which there is required training. I mean, your point, Mark, that very few people are trained to essentially use the medications in a way that essentially assist in the transition for folks. What can we do? I mean, we are a mecca of medical education in this state. We produce more docs per square mile than just about anybody. Nurse practitioners and others who are essentially engaged with the community. What is it that we need to be doing either in terms of monitoring, in terms of registries, in terms of limitations on prescriptions? Rather than 60 days that you limit essentially the first time out, so you're not sending somebody home with a toothache with 30 days worth of opioids. What's going on in that respect? What kind of work is going on at the state level, both in terms of the registries and pharmaceuticals, but also in terms of our medical schools?
Well, there has been an increased emphasis on education among medical students and residency programs about proper opioid prescription. I don't think it's the case, though, that overprescribing by doctors, again, are the major cause of the epidemic we're seeing. And although most patients who end up on heroin or fentanyl began with an oral opioid pill, many of them were diverted pills and not actually from a doctor's prescription. And I also worry about us going too far on the other end. There are plenty of patients with legitimate pain that need opioids that now can't get access to them because doctors are so afraid of prescribing. So I worry about going too far the other way on that.
And Alex, I'm wondering in terms of the community and the community's response. I mean, to Mark's point, there are people with chronic pain. There are real issues that need to be dealt with. I was somewhat surprised to learn that the issue is not only with physicians, medical physicians, but also with dentists, and essentially assisting the dental profession in understanding the implications. But I wonder from the community perspective, how are they reacting to these questions?
Well, I'd say in our community there's a lot of anger toward the pharmaceutical companies. And I think that I agree that none of my friends that passed were prescribed by a doctor. That being said, the marketing of the OxyContin was fraudulent. I mean, it's a disgrace the way they marketed that, and they mismarketed that, and they misled the doctors and spent all this money on marketing. And those drugs ended up in a lot of medicine cabinets, and it doesn't, the word spreads pretty quickly when there's a drug in medicine cabinets that can get you high, and and quickly people realized, because they were so popular and so many people were getting their hands on them, diverted, not necessarily straight from the doctor, but there were just so many people were going into their grandmother's cabinets. I heard people that worked for moving companies. When they were in a moving company, the first place they'd look was the bathroom because they're in the check to see if they're there. And then, it didn't take long for people to just start robbing pharmacies. There was, I went through my research for the documentary. I went through old newspapers, and just in my neighborhood, there were 9 pharmacy robberies between like September and December of 2001, and that each one of them just netting thousands of pills. So it just flooded the street, and as much as it wasn't, not necessarily a direct line from the doctor prescription to the users, it's not that much. There's not too much in between. It's a pretty direct line. And then and as far as the medically assisted treatment goes, I agree. I think it's good. It's not ideal. I think people like to make the argument like, oh, you're using an opioid to get someone off an opioid. But the analogy I like to use is it's like a tobacco patch, a nicotine patch. It's still the same drug, but at least you're not smoking. So you're still getting the analogy being, instead of having all the damage you're doing from inhaling tobacco smoke, you're not getting the damage it is from intravenous drug use, but you're still getting the relief from the withdrawal symptoms by having the base chemical being similar.
I want to open it up to our audience, but before I do, I have a question that I'd like each of you to think about, and that is from a federal perspective, given all the conversation going on in Washington with the big summit today, with Scott Gottlieb doing his announcement on his registries, what is the one thing you would like the federal government to do? Now, an answer may be nothing, but what is the one thing that you think the feds could assist you as a state legislator, you as a physician, you in a community leadership? What is the one thing the feds could do?
I have an answer for that.
Great.
Don't mess with our marijuana legalization. No, I mean, really, I mean, I think there's a good chance that legalizing marijuana will help our problem, and it'll certainly help in a whole lot of other ways from a criminal justice standpoint. And the notion that these guys are going to mess with that's a bad thing.
Got it. Alex?
I think, unfortunately, I feel like there's, this many years later, we're still searching for a silver bullet. But I think just funding, if we could just get more funding for this problem, more research. I think we just need to throw everything we can at this issue right now, because how many years later it's still persistent and only getting worse year over year. And I don't know that there's one law I could see passed that I think would do that would have this huge effect. But I think I'd love to see more toward research.
Well, one of the, as I mentioned, there is Democratic members of the Senate have written to the GAO and requested an investigation of whether the administration is spending the money. I mean, there were many billions of dollars that were included in the legislation in the fall and in the Cures Act and also in the context of the Budget Act to ask whether the money's being spent. So to your point, is it on treatment? Is it on research? Is it on data tracking?
All of the above.
I think that question's going to be asked. And Mark, what's the
one
thing?
So I would follow Portugal's example, who decriminalized drug use 20 years ago. And the money they spent on incarceration, they spent on treatment, on job training, on subsidizing employers to hire people with drug addiction. And over the last 20 years, their rate of heroin addiction has dropped by 50%. Their overdose death rate has dropped by 90%. Their HIV rate has dropped by, I think, 3 or 4-fold. So it'd be a radical approach, but I think that was what I would go for.
It's an interesting thing, and then I'll turn to our mics. There was a piece that was reported recently that in the state of Indiana, interestingly enough, in working with employers, that they are looking at ways to essentially, if someone fails a drug test upon applying for a job, that they essentially allow them to reapply if they agree and commit to going into treatment. That there is, in fact, sort of a work going on to try and get acceptance among the employer community to essentially give people a second chance and avoid some of the issues the senator raised. Let me begin on my left, name and affiliation and question mark at the end.
My name's Jim Stewart. I run the First Church Shelter here in Cambridge, Massachusetts. I've been there for 30 years. I also work with a group called Safe Injection from Massachusetts.
Jim, let me make sure your mic is on. Is the mic on my far left? Great, thank you.
Jim Stewart, First Church Shelter, Safe Injection from Massachusetts now. Back in 1992 or 91, they were trying to open a needle exchange in Harvard Square. And I know we all feel pretty smug here in Cambridge about how hip we are about dealing with this issue, and that a lot of parts of the country should be following, a lot of parts of the state should be following our example. But you couldn't get anybody in Harvard Square to agree to host a needle exchange. So our church, because we feel like we have an obligation to be a welcoming community and to make it clear that we want the benefits that we enjoy to be available to others, said, all right, we'll run it here. You can just come here and distribute the needles here. And eventually it was demonstrated that it wasn't a big problem, and they eventually decided they could get better quarters someplace else. But we had them for more than 5, less than 10. I can't remember exactly how long it was. And I'm still staggered at the stigma, the sort of other category that people with substance use disorder are thrown into. It's like, oh, well, you've got substance use disorder, and usually what they say is, well, you're an addict, right? And so therefore, if you keep making bad decisions with this relapse disease you have, then you just have accepted the risk to die. And I'm just wondering if the panelists have any kind of idea about how we can hold up in higher profile the humanity that the people we're calling we're concerned about here. Because if you took another group of people and said, well, you're a blank, and put in, gay person, person of color or something, because you have that, you've essentially agreed that it's okay for you to be treated as the other.
Thank you, Jim. Anyone on the panel?
Yeah, I think
Alex?
yes. I totally agree. I think there's still too much stigma. I will say that I think it's getting better, especially in communities around here. If for no other reason than it's because the problem's so bad, everyone knows somebody, or if you don't know someone directly, you know somebody that knows somebody that has the issue, has been using. That being said, we have a long way to go. And of the families that I've spoken to, many of them are in favor of not only needle exchange programs, but safe injection sites. They don't feel that they would have wanted their son or their daughter in one of them. One of my friends, the parents that were in the clip I showed, their son died in the bathroom of a taco shop, and I think they would have much rather him be in a safe injection site. I do think that, yes, we have a lot of problems getting these places approved. I know one of the issues is that they have to be, I believe, with safe injection sites, if they're not someplace where drug users congregate, they're not going to go out of their way to drive to another city to use it. So they need to be in more or less downtown Boston. But the NIMBYism is tricky. But hopefully, as more and more people are touched by this, and more people advocate for it, maybe we'll crack that issue.
Good, thank you. Did you want to say something, Senator?
Well, I want to make sure we get back to people.
Please.
My name is Noam Yousefi. I'm a master's student at the Chan School of Public Health. Thank you so much for sharing your insights with us. My question is for the senator, but I'm happy to open it to the panel. We've seen a lot of cities in Massachusetts look into or dedicate funds towards litigation against pharmaceutical manufacturers and distributors. Mayor Walsh recently came out saying that he's looking into a similar initiative in Boston. My question is, do you think that this is a worthwhile endeavor to raise revenue for treatment and for prevention? Or do you think that because most of the deaths that we're seeing are related to fentanyl and other illegal drugs, that this is not really an accurate remedy for the problem?
Good question.
Great question, and one that I don't think I can answer. I mean, I think there's a question that lawyers need to ask as they consider a lawsuit, which is, will this work? Do I have the evidence that will support a cause of action, that will lead to recovery, or is credible enough, could lead to recovery? And I haven't seen that assessment myself. I mean, I think you raise a good point as to, what's really causing the death? What are the harms? How straight a line can you draw? I don't know the answer to that.
The state of West Virginia got a big settlement about 5 years ago.
Yeah. So there's an encouraging example.
Good, thank you. Up to my right.
Hi, my name is Maya Jenkins, and I'm a freshman here at the college. And I was wondering if you all could speak to the racial discrepancies that we've seen in drug policy, especially when it comes to the war on drugs, where communities of color were demonized and criminalized, when it comes to how people have been wrapped up in the incarceration system, specifically people of color, and how we're shifting now to viewing the drug issue as a public health issue, but we're thinking about that in a very racialized space where it really comes down to white people now being viewed as those who are being hit hardest by the opioid crisis. I was wondering if you could speak to the different challenges that that race creates in this space.
Yeah, Mark?
Well, I completely agree with you that we treated it differently before when the people who were dying were using drugs were people of color. So that doesn't mean that it was right before that we shouldn't do a better job now. And the New York Times had an article about overdose deaths increasing in the South Bronx. So there is out, and in Philadelphia, so it's happening in communities of color also. So I think we need better treatment, but you're right that it didn't really grab people's attention until.
Well, and I think that Alex has touched on it, which is all of a sudden it looks like me. all of a sudden it's a relationship to somebody in my community, somebody that I know, which is a very different experience. And there is no question that historically the discrepancy between the treatment of people of color and Caucasians has been marked in a host of ways, not only drugs, but heart disease, all sorts of things where access and treatment were not as readily available. So I think the fact that the profile has risen in part because it is now a different circumstance, a different population. But it underscores the fact that we have failed to deal with it fairly, I think. Absolutely. I think you're absolutely right. Yes.
Hi, my name's Remy Hill, and I'm a sophomore here at the college. And as a follow-up, I guess, to Ms. Jenkins' question, for the senator, I heard you mention a little bit about sort of allusions to the lessons that we've learned from the war on drugs and how we should learn from that when we're thinking about the role of the criminal justice system in this battle against opioids. And then you just mentioned avoiding having the federal government infringing on Massachusetts' attempt to legalize marijuana. And I guess I'm wondering how you as a legislator think about righting the historical wrongs of the war on drugs, especially as they pertain to racialized incarceration and things like that when it came to marijuana specifically.
Well, that's a really complicated question. The main thrust that I'm focused on today as a legislator is a broad criminal justice reform package, which is oriented to lifting people up instead of locking people up, to cutting the chains that hold people down when they are trying to get back up on their feet. And that is from soup to nuts in the criminal justice system. And so it goes beyond any one narrative about one drug or one type of crime, but what we did in Massachusetts and really in every state in this country, which is sort of an amazing kind of thing that this all happened in parallel, is from the mid-'70s to the mid-'90s, we quintupled our prison population in Massachusetts. And that had some to do with a rise in crime that really happened in the 60s that we didn't really start responding to until the 70s. But it was clearly a decision to become much more punitive. And that decision has had its hardest impact on communities of poverty, and not only communities of color, but yes, to a larger extent, communities of color. And we now need to try to reverse that and recognize that the incarceration itself has become a problem. And not only the incarceration, but all the sort of things that are around incarceration. The aftermath of incarceration, the experience of being on parole, or the experience of being on probation, which might occur before or after incarceration, and charging people for the privilege of being on parole, charging people for the privilege of being on probation, preventing people from being able to drive, a host of things. And these are things that the legislature did that make it harder for people to get back up on their feet. And so we've got a package that we are in the middle of negotiating. The House has got a good bill. We passed a good bill. The House passed a broad bill. And I am really hoping that over the next, honestly, few weeks, you're going to see some major things come down here in Massachusetts that will hopefully make a difference.
Thank you.
Thank you. To my left.
Hi, I'm Sanjay. I'm a medical student at the university, and I'm here with a couple of my classmates. Thank you guys for hosting this. My question, Senator, I think if I heard you right, you mentioned the biggest barrier to having a safe injection facility was actually that no real organization wanted to step up. I just got off a 1-month rotation at Boston Healthcare for the Homeless, an organization in downtown Boston where overdose has become the leading cause of mortality among homeless folks here in Boston. They have this place called The Spot. I don't know if folks in the room have heard about it. It's an observation unit where there are 10 chairs, 2 nurses, fully staffed, folks who use right outside comment and are monitored for 8 hours. Basically, in their vision, it's the closest thing to a SIF that we can have in Massachusetts. And after talking to the chief medical officer and the leaders, if you gave them the permission tomorrow, they would turn it into a SIF. So my question to you and to everyone else on the panel is that really the barrier, that there aren't providers that are willing? What are the real barriers to having a SIF here in Boston?
No, honestly, I know Boston Healthcare for the Homeless. They come into my office and say that they're ready to work. I'm ready to work. Okay. They've not done that. They have not done that. They may be saying something to you, but you get the head of that organization to step up to the plate. I'll work hand in glove to make it happen.
Okay.
So by the way, you need to understand this. He has to have a partnership with the mayor of Boston. And so far, the mayor of Boston has been against SIFs. So Boston Healthcare for the Homeless, I suspect, I don't think this is a delicate thing to say, is walking a very fine line with the mayor of Boston right now. So that's the equation we're dealing with.
One logistical answer to your question, though, is Boston Healthcare for the Homeless gets federal funding, and they're afraid they'll lose their federal funding if they open up this facility given the present administration. So that's a specific barrier.
I know we can go on for a long time, but we have 5 minutes, and so I'd like to do a lightning round. So we're going to go quickly. Quick question, quick answer. We'll get as many in as we can.
Yeah, they are PhD student at the School of Public Health. And I think my question here is like this redefinition of this opioid crisis or opioid epidemic as a loneliness epidemic. We know that we have a lot of deaths related to despair, like suicides, and this is one of these. And America is very famous for being overdosed in many extents. So I wonder if we can redefine this to being alone, loneliness epidemic.
I think it's, and Mark was talking about it before, there's a bigger picture out there of reasons that people in society are using drugs right now. A level of hopelessness and anxiety that is a big part of the picture that we need to be thinking about.
One of the things that I think people have begun to appreciate more is the social determinants of health and the contributors, whether it's homelessness, education levels are an enormous contributor. Frankly, food deserts, the fact that people are hungry. There are a whole host of things that I think we're only now really truly appreciating have an enormous impact on people's health. And I think are finally beginning to address the linkage between those pieces. So it isn't housing here and healthcare here, it really has to be intersection. I think it's right. To my right.
Hi, my name's Rachel. I'm a local citizen, teacher. My question is really about treatment. So how do you see us really opening availability of treatment, but also to really crack down and really regulate treatment facilities?
Mark?
So I've been, for the last 15 years, going around the city, going to practices, trying to encourage doctors to provide treatment. There's still the incredible amount of stigma. Doctors don't want these kinds of people in their waiting rooms. They don't want to take care of these sorts of people. There's still the whole blame, like there was around the AIDS epidemic, that it's people's fault and their choices and their bad choices. So I think, again, going around, we mentioned earlier, erasing the stigma that people have around addiction is going to encourage people to provide treatment.
Go ahead.
Funding, right, which we're definitely pushing on, but the issue of quality of treatment, which we may have been pointing to, is a very, very big issue, and I don't think we're doing a good enough job on assuring that treatment is actually of good quality. There's some wonderful treatment out there, but there's also some treatment that isn't so good.
And because I've had a friend who's died in treatment because it's an unregulated facility.
Yeah, I was just going to get to that. That's a huge problem as well. There's a lot of people that are a lot of organizations out there in Boston, but particularly down in Florida as well, that are running just really scams, more or less, that are taking insurance money, not treating people at all, and just profiting off of tens and hundreds of thousands of dollars in insurance money. And because there's so many addicts out there, they have a lot of people to prey on. So you have to be very careful about these treatment companies. And we have to make sure that we can put a system in place that can point people to legitimate treatment.
And this is not an issue that's unique to this circumstance. Medicaid has faced this for years, where people didn't want them in their waiting room. They don't want people that look like this mixing with their patients. So it's an issue we've confronted on the poverty level and those issues for programs as well as in this case. You're going to get the joy of the last question. So make it quick.
My name is Dan Alroy, and I was wondering, we have incentivization to get medical professionals into the field. What about the people under that, like therapists, counselors, rehab, peer coordinators? How is the state and how's the medical community trying to incentivize people to get there and take away the barrier, like education?
And also first responders, a host of people.
My lightning answer? Funding, right? So that you can have people making enough money so that they'll stay in a facility. The volume of turnover at every level in the treatment system is staggering.
Mark?
Yeah.
Anything other? Alex, any final comment?
I just like to, I think that from a community standpoint, the people that are dealing with this issue, I think that they're just open to any and all, whether it be treatment, legislative promises, I think possibilities, and I think that just something has to give. I feel like they feel like that we got to try something because the status quo clearly isn't working, and in my case, I feel like my generation, we've almost lost everyone that has used. I mean, it's like my group of friends, it's almost like our little nightmare's over because everyone that's been using it has already passed. But we just don't want to see it continue to happen to the next generation.
Please join me in thanking our speakers.
Thank you.
Thank you very much.